Important disease, this is called a retinitis pigmentosa. Please see, this is retinitis pigmentosa and it is due to a programmed cell death of the rods of the eye. Please remember, it's a disease of the rods and not the cones. This can be asked as a question, and it is due to the apoptosis of rods. It is an autosomal recessive disease, most commonly, very common it is. So it is more common in consanguineous marriages that are very rampant in our country. So it is an autosomal recessive type of disease. However, sometimes it can occur as an autosomal dominant type or an X-linked type. When it is an X-linked type of retinitis pigmentosa, it's going to have the worst prognosis. Okay, let's look at what the patient presents with. The clinical features, the first and most striking feature of this is Nyctalopia. We know that Nyctalopia is night blindness. How will you know that a baby is having night blindness? You can see the mother complaining to you that as the evening sets in or during the night time the baby is cranky or just sits at a place and stops playing, whereas he or she plays during the entire day. That is an indication that the vision is reduced during the night time. This is how the baby can see or the child can see in the night time. Then there is a ring scotoma that is present, and then slowly this Nyctalopia progresses into a tubular vision because there is constriction. Suppose this is a visual field of the child, it goes on constricting like this. All of this vision decreases and finally the child is left with what is called a tubular vision. Let's look at a ring scotoma. All of these lines, this area, the gray area is my area of ring scotoma. You can compare it with how the patient sees in real life. All this area is the ring-like area that he cannot see. That is the ring scotoma. He can see within the ring and outside the ring, but not in the ring. Okay, that is your ring scotoma, and our tubular vision or tunnel vision, this is what the patient is going to see. There is absolutely no peripheral vision and he is only left with a central tubular vision. Now, coming to the characteristic findings when you examine the fundus of a retinitis pigmentosa patient, this triad you will have to remember. This can be asked as a question. Please remember, it's a pale waxy disc, number 1. Then there is arteriolar attenuation, and number 3 is your bony spicule-like pigmentation. All of this black pigmentation that you're seeing is very characteristic of retinitis pigmentosa. Okay. So this is the triad. It's a pale waxy looking disc. If you observe the disc, it's very waxy and very much pale. Normally it is reddish pink in color. Here it's looking very pale. And then there's arteriolar attenuation. You can see the vessels that they are very thin. That is attenuation. And then the pigmentation is bone spicule pigmentation. Now the gold standard to diagnose retinitis pigmentosa is ERG. Though you can see these findings, you can only confirm on an ERG. What is an ERG? You're going to place the electrodes, one on the forehead of the patient and another on the cornea of the patient with the help of a contact lens. From these two electrodes, you will measure the potential difference of the neurosensory layer. And in retinitis pigmentosa, the ERG becomes flat. ERG is flat or extinguished. It is called an extinguished ERG in retinitis pigmentosa. Let's look at a normal ERG over here. There are 3 types of waves: the negative A wave, then the positive B wave, and a small C wave that is rarely seen. This is the ERG of a normal eye, which has different waves depending on the stimulus type of the light, the blue, red or scotopic white or whatever it is. Then in retinitis pigmentosa you can see there's hardly anything. Okay, it's almost flat in every case. That indicates a extinguished ERG. So what does this A wave mean? It measures the potential difference between the photoreceptors, that is the rods and the cones, and the B wave measures the potential difference between the Muller cells and the bipolar cells. The Muller cells are the neuroglia of the retina, and the bipolar cells are the neuronal cells of retina, and the potential difference between these two is measured by the B wave. Let's look at the treatment of retinitis pigmentosa. Please remember this number very carefully. It is asked many times. You can give 15,000 international units per day of vitamin A in palmitate form every day, lifelong. Okay, lifelong, you give it lifelong. 15,000 international units per day of vitamin A in its palmitate form needs to be given. Now, such a high dose sounds as if it is toxic, but please remember that it is not at all toxic. When the dose crosses 25,000 IU, then it can be toxic. Okay. However, because it is teratogenic, you are going to avoid it in pregnancy. Okay. Whenever the lady with RP is pregnant, you are going to avoid this vitamin A dosage. The important thing you have to note over here is that it doesn't cure RP. There is no cure for RP. Remember, there is absolutely no cure for RP. However, it delays the RP by about 7 years. 7 years may sound less, but it is of a very long duration for a patient with retinitis pigmentosa. So, it delays the disease by 7 years. Usually, the patient becomes blind by 40, but you can delay it by 7 years if you supplement the patient with vitamin A. Kindly do it and kindly remember this. Okay, now there are some interesting syndromes and very frequently asked in your exams that are associated with retinitis pigmentosa. The first one is Basson-Conway, then Lawrence-Moon-Beadle syndrome. Now, Beadle and Bardet syndrome is separate from Lawrence-Moon syndrome. So, Lawrence-Moon syndrome and Bardet-Beadle syndrome. Then, Usher syndrome. Please remember, the most commonly associated symptom with retinitis pigmentosa is Usher syndrome. Then, Refsum syndrome. Basson-Conway, Lawrence-Moon, Bardet-Beadle, Usher's, which is most commonly seen in RP, and Refsum's disease. All of these are